Hello all. So today I will be discussing regional anesthesia for safer outcomes in mucopolysaccharidosis with difficult airways. Are we seeing a paradigm shift? This is a case report, a 6-month-old MPS type 3 known case presented with bilateral obstructed inguinal hernia and was posted for emergency herniatomy. The birth history stated that it was a late preterm baby delivered by caesarean section due to oligohydramnios with a birth weight of 1.67 kilos. A significant history included one episode of community acquired pneumonia at 5-month age which was managed conservatively, and the baby has snoring and noisy breathing as reported by the mother. On examining, it was a poorly built baby. It had micrognathia and mild retrognathia, severe subcostal retractions, grunting and stridor. On head-to-toe examination, we see that this baby has got coarse facial features with a prominent forehead, extremely loose and lax skin with multiple skeletal abnormalities which included pectus excavatum, mesomelic dwarfism and restricted movements of all small joints. The spine appears normal on clinical examination. On a general physical examination, it is an conscious active baby with normal vital parameters. On auscultation, it has bilateral coarse vesicular breath sounds. The developmental milestones are overall delayed. On local examination, we found that it has got bilateral inguinal area swelling with the skin over the swelling appearing bluish pink in color, and it was tense. The investigations which were present for this baby were CBC, 2D echocardiogram which were normal, eye and ENT examinations were normal, and whole exome sequencing confirmed the diagnosis of MPS type 3. So, the provisional diagnosis is a 6-month-old male known MPS type 3 case with bilateral obstructed inguinal hernia and was posted for emergency bilateral herniatomy. So, what is MPS? MPS is a lysosomal storage disorder where there is accumulation of glycosaminoglycans in all connective tissues, including cardiovascular, pulmonary, GI, neurological and musculoskeletal systems. Glycosaminoglycans in the upper airway leads to hypertrophy of the adenoids, tonsils, tongue and laryngopharynx. Hence, different studies have reported difficult mask ventilation and difficult tracheal intubation in these patients. This chart depicts the different types of MPS with their associated clinical manifestations. The features which contribute to difficulty in their airway management have been put in bold, like MPS type 1 or Hurler syndrome, presence with facial dysmorphism and OSA. MPS type 2 or Hunter, presence with macroglossia, vocal cord enlargement with narrow airways and OSA. MPS type 3 or Sanfilippo, it presents with enlarged tonsils, adenoids and respiratory infections. MPS type 4 or Morquo, it presents with atlantoaxial deformities and restrictive lung disease. MPS type 6 has restricted joint movements, whereas MPS type 7 also is associated with multiple skeletal dysplasias. So, the anesthetic concerns in MPS patients include difficult airway because of hypopharynx being narrow, large tonsils, adenoids. There can be neck pathologies like cervical cord compression, atlantoaxial instabilities. In oral cavity, there is presence of a large tongue with limited mouth opening. Cardiovascular system may present as coronary heart disease, valvular disease or heart failure, significant arrhythmias and pulmonary hypertension. The respiratory system presents as restrictive lung disease, obstructive lung disease or narrow airways. Hence, keeping these concerns in mind, the anesthetic goals for such patients include anticipation of a difficult airway and accordingly keeping difficult airway cart ready. All drug doses are to be optimized, especially anesthetics and opioids, keeping in mind their systemic involvements. Intraoperative and postoperative ventilation strategy, keeping in mind their respiratory system and cardiovascular system compromises. Anxiolysis and pre-medication, especially in children who have intellectual disabilities. Individual disease-specific concerns are to be kept in mind according to the subtype of MPS. So, this slide here represents literature review where a systemic analysis of 49 Mayo Clinic patients with MPS undergoing various surgeries under general anesthesia was studied. The pie chart here depicts the choice of the primary airway in all these patients. In this, we can see majority of the patients were managed with a direct laryngoscopy followed by video laryngoscope, and others included mask anesthesia, laryngeal mask airway, fiber optic intubation. However, a significant proportion of these patients represent difficult airways which were already having a definitive airway in place. The chart on the right hand side depicts various studies in literature which have reported failure of intubation in different subtypes of MPS, and the numbers are quite significant. So, regarding regional or neuraxial anesthesia in MPS patients, what does evidence suggest? Possibility of failure of epidural anesthesia, mainly because of deposition of mucopolysaccharides in the general epidural space or the sheath of nerve fibers. However, subarachnoid block does not pose such problems. There is technical difficulty due to the musculoskeletal deformities, particularly scoliosis, kyphosis, and dwarfism, short stature, unpredictable spread of drugs. Positioning may also be difficult because of the intellectual or behavioral disabilities. In our patient, the plan of anesthesia was a subarachnoid block with mild sedation. So, preoperative preparation included standard nilperoral guidelines. Other than that, postoperative ICU with a mechanical ventilator was kept standby. A fully informed and written consent was obtained from the parents, which included informing them about the plan of spinal anesthesia, possibility of it being converted to general anesthesia in case spinal is found to be difficult. All the risks associated with general anesthesia in this particular baby was also informed to them. In 60 minutes prior to the surgery, in the pre-op room, EMLA patch was applied to the skin on the dorsum of the right hand as well as on the lumbosacral spine in the midline. OT preparation included a difficult airway cart, including video laryngoscope, fiber optic bronchoscope, and all other conventional equipments. Apart from this, the OT was kept ready for an infant, including warming mattresses, micro drip sets, soft jelly pads and cotton rolls, all GA and emergency drugs, and equipments and drugs for a subarachnoid block. And the procedure of conduct of anesthesia included: once inside the OR, all standard ASA monitors were attached to the baby, and an IV cannula 22 gauge was obtained in the right hand dorsum. Sedation was given using IV midazolam 0.1 mg per kg, fentanyl 1 microgram per kg, and ketamine 0.5 mg per kg, following which a gentle bag mask ventilation was done to check for adequate ventilation should there be any requirement of it later on, and to make sure that there is no difficulty in managing the upper airway patency. After this, the baby was put in left lateral position along with oxygen via nasal prongs at 2 liters per minute, making sure that the baby is breathing spontaneously, and for this ETCO2 monitoring was continued. These videos in this slide are not of the same patient, but this is exactly how we perform spinal anesthesia for neonates and infants in our institute. As we can see, nasal prongs have been placed after positioning it in a left lateral position. The spine was made into a C shape as is recommended by standard guidelines. After sterile dressing and draping, we will feel for the spinal space. In this patient, L5-S1 space was chosen, following which local anesthetic was infiltrated. Then a 25 gauge Quincke's needle was inserted, and once free flow of CSF was confirmed, then heavy bupivacaine 0.6 mg per kg was injected, after which the baby was positioned supine. Now when we see the other video, we can see how the baby is breathing spontaneously, the movement of the chest and abdomen apparent, and the surgeon has started painting draping. So the post-operative course, the baby was monitored for 30 minutes in the PACU after the procedure was completed, and it was shifted to ward once its modified Broman score was 6 and had passed urine. In the ward, it was started on oral feeds and it followed an uneventful post-operative course. It was discharged on post-operative day 3. To summarize, this case report summarizes a successful case of management of an infant with MPS type 3 with neuraxial anesthesia along with mild sedation, making sure that the baby is breathing spontaneously. However, preparedness for failure of regional anesthesia was done, and we had anticipated and planned for a difficult airway. In this patient, the individual specific concerns were also kept in mind. These slides, subsequent slides, represent few other MPS cases which has been managed in our institute. This particular case is an 11-year-old male with MPS type 4, presenting with bilateral genuvalgum deformity and was posted for bilateral knee corrective osteotomy. His issues were difficult airway with a kyphoscoliotic thoracic spine, severe restrictive lung disease, and snoring. For this patient, the anesthesia plan was a combined spinal epidural anesthesia at lumbar level with airway secured by supraglottic airway, and spontaneous ventilation was maintained using air, oxygen, and sevoflurane mixture. This case here is a 13-year-old male with MPS type 2. It presented with umbilical hernia and was planned for mesh hernioplasty. His issues were a difficult airway, seizure disorder which was on treatment, OSA, mitral valve prolapse, and severe intellectual disabilities. In this patient, the plan of anesthesia was GA with a supraglottic airway device. Rectus sheath block was given for analgesia along with minimal doses of opioids. Hence, to conclude, MPS presents a unique set of anesthetic concerns for which an adequate knowledge of the disease pathophysiology, anticipation of the specific problems according to the subtype of MPS is needed. An individual tailor-made anesthesia plan is required to succeed. Neuraxial anesthesia can be found to be a safe and efficacious approach in such patients wherever it is suitable. Further literature, however, is needed to support its safe, effective use, particularly in neonates and young infants. Thank you.